Good afternoon, and thank you all for joining us. My name is Andrea Matu, and I'm an engagement and adoption lead with Amplify Care. This session will be recorded and the lines will be muted. You're encouraged to ask questions in the Q&A panel located bottom center of the screen. Amplify Care is a not-for-profit founded as the eHealth Center of Excellence in 2014 and was established to support clinicians and their teams with the innovative solutions that meet their needs and improve patient experience. Our goal is to use technology to enable improved clinical workflows and enhance patient outcomes, empowering clinicians with tools that reduce administrative burden and improve patient care. We are a trusted partner for healthcare professionals and organizations, offering a range of capabilities that simplify workflows, streamline administrative processes, improve population health management, and ultimately improve patient outcomes. Our mission is to be the leading trusted digital health partner for primary care and integrated patient care. You can find out more about us at www.amplifycare.com. Today, we are thrilled to have you join us for our sixth of a year-long webinar series focused on reducing administrative burnout, improving the clinical experience, and patient experience. The overall goal of the webinar series is to provide primary care clinicians with actionable items that can be implemented to help support in one's day-to-day workflow. This work is part of a larger project Amplify Care will be undertaking to co-design alongside primary care clinicians of what the ideal family practice model looks like. Before we get started, we'd like to run a few polls that will help guide our presenters today. The first question is, what is your current role? Primary care physician, nurse practitioner, practical nurse, specialist, clinical office manager, clinical administrator, or other. Okay, we have a lot of others I see today, and a few others that are filling the boxes there. Okay, great, thank you. We do have a second question here for you. The next question is, what type of practice do you work within? So community health center, nurse practitioner-led clinic, Indigenous primary healthcare organization, family health team, family health organization, independent practice, or again, other. Okay, and a nice variety again. Wonderful, thank you everyone. Today's session, Optimizing Primary Care Efficiency Through Interprofessional Healthcare Providers, Integration and Team Collaboration, will be co-hosted by Julia Hutton and Teresa Wetselaar. Julia Hutton is a clinical advisor at Amplify Care and a dedicated primary healthcare nurse practitioner with the Center for Family Medicine Family Health Team. With a Master of Science in Nursing and over 15 years of clinical experience, Julia delivers comprehensive care with a focus on women's health, chronic disease management, and preventative medicine. Julia began her career in emergency medicine at Mount Sinai Hospital and later broadened her experience as a nurse in Australia. Since becoming a nurse practitioner, she has served in diverse primary care settings, including the Guelph and Upper Grand Family Health Team, where she developed deep expertise in interdisciplinary collaboration and patient-centered care. Alongside her clinical work, Julia has a strong interest in digital health innovation. She brings her frontline experience to her role at Amplify Care, supporting the implementation of virtual visits, healthcare solutions, and quality improvement initiatives. Her passion for integrating technology into healthcare is driven by a belief in improving access, efficiency, and outcomes in primary care. Teresa Wetselaar is the nurse practitioner lead at the West Parry Sound Health Center Rural Nurse Practitioner-led Clinic, where she also manages 2 clinic sites. She leads the Rapid Access Addiction Medicine Clinic and provides care through the Sexual Health Clinic at Parry Sound Health Unit. With a strong passion for primary health care, Teresa is a dedicated advocate for the full scope of nurse practitioner practice in Ontario and supports scope expansion for other healthcare providers. She began her nursing career after earning a Bachelor of Science in Nursing from Ryerson University with a focus on renal care and chronic disease management. She later completed her Master of Nursing at Athabasca University. Julia and Teresa will share their top tips for improving practice through interprofessional healthcare provider integration and team collaboration. We encourage lots of questions as your input will help enrich the conversation today. Please welcome Julia and Teresa.
Thanks, Andrea, for that lovely introduction. So I'm just going to go over quickly the agenda here. So after the welcome and introduction, which we've already had, Teresa is going to start by talking a little bit higher level in terms of team-based care, maximizing scope of the team in general. So general terms, pros, cons, benefits, risks, all of those things. Then I'm going to get a bit more specific into different types of specialty clinics that nurse practitioners and interdisciplinary health clinicians can provide within a primary healthcare team. And then we'll have some time at the end for discussion and questions. But as Andrea mentioned, do feel free to put any questions into the question box throughout the presentation, and we're happy to try to answer those as we go. And then if not, we may save some to the end, but go ahead and interact with us as much as you'd like. We encourage it for sure. All right, over to you, Teresa.
Thanks, and thanks for joining us today, and thank you, Amplify, for asking us to present on this. So just going to go over the current state of primary care in Ontario. As any primary care provider knows, Ontario is struggling to provide primary care to its people. There's currently an estimated 2 million people without regular access to primary care, and that number is anticipated to increase. So people without a regular provider often use walk-in clinics or emergency rooms for their primary care needs. This is costly and not a good use of our healthcare dollars. And we're also missing out on preventative care screening, cancer screening, vaccinations, and using spots in emergency and urgent care for people who would better be suited in those areas. Next slide, please.
I just want to say, having worked in an emergency department, a very busy downtown Toronto emergency department, I can really testify to the fact that people who do not have a primary care provider are showing up in the emergency department at much higher numbers than people who do have a primary care provider. So definitely something to think about. And, there's lots of conversations happening on how we can attach patients, which is great. But yeah, that definitely is happening.
Absolutely, Julia. And again, we're missing, like primary care providers are missing information, potentially emergency room visits, and follow-up care. Anyway, team-based care in Ontario, only about 15% of Ontarians have access to team-based care. So it's growing in Ontario. There's additional funding coming through by the province and Ontario Health to increase team-based care. And unfortunately, some teams may not be using their providers to full scope, and we're going to talk about that today. So organization of healthcare, this is changing again in Ontario. Single providers or solo providers may not have an access to team. There is a team care through the Alliance that they can access for team-based care and help with that. And then again, the scope of practice can be possibly expanded for providers. Next, please. So what is team-based care? So it's a group of professionals coming together to work collaboratively and at their maximum scope to provide primary care to a group of people. So the group of professionals are included here. And just to point out, in team-based care, the nurse practitioners and doctors are hopefully seen as the MRP, most responsible provider. So there's a few examples of team-based care in Ontario. Nurse practitioner-led clinics, which I'm a member of, family health teams, which Julia is currently working in, community health centers, and IPHCOs. Next slide, sorry. So I'm going to plug nurse practitioner-led clinics because that's what I'm involved in. So this is a primary care team-based model that has NPs as the leadership at all levels of the organization. These are funded by Ontario Health, and we take on a group of patients and follow them comprehensively through time. We work with teams. So my team involves a RPN, physiotherapist, social worker. Julie, I know you work in a family health team. What sorts of providers do you have in your team?
It's yeah, very similar. We've got social workers, dietitians. Um, it really depends on the family health team as well. I've worked in 3 different ones, and there's been occupational therapists, physiotherapists, pharmacists, physician assistants. It's such a broad range, and every team seems to have the funding for different team members. So it really varies, but yeah, wide variety.
Absolutely. Thanks, Julia. Next slide, please. So how to work together as a team. Team members obviously must work together collaboratively and communicate amongst themselves to provide care for the group of patients. Extra education may be needed to work collaboratively and communicate effectively. I know as nurses and nurse practitioners, we have extensive baseline education on how to work collaboratively and communication strategies and conflict resolution. So conflicts again may arise. We're working with a number of team members who have overlapping scopes of practice, and um, uh, who does what may come into play. So when you're developing a team, you want to have initial team meeting to develop how you do things and who is responsible for what, um, and a plan of care. You can also meet your team members to discover what is their scope of practice, what can they bring to the team. Regular team meetings are also helpful, and regular meaning either weekly or monthly. What's working, what's not, some program evaluation, regular in-service days. Your new team members may not know how to do, certain things like a well baby check. So learning how to do those. Shadowing, so having your RN or RPN shadow you so they can maybe point out things that they could do instead. And then quality initiatives are always a good place to start. They have standardized guidelines and pathways. What other techniques do people use or you use to work effectively as a team? Julia, any?
Yeah, the biggest one that I find is important is team meetings.
Yeah.
So having meetings with everyone at the table. The meetings that make decisions tend to be very physician heavy, which can be an issue because there's so many things that other clinicians can offer, ideas, different things that they can bring to the table, and so really important to include everybody. We always, the other nurse practitioner and I at this office used to like to always say, no decision about us without us. And so that's important for all team members. I've worked at 3 different family health teams, and the ones that include everyone in decision making tend to have the best outcomes in terms of patient satisfaction, uh,
Mhm.
job satisfaction, all of those things. So that one is really important from my perspective for sure. Does anyone else have anything? I don't know if you can put it in the chat if you have anything else that things that work well for people. Um, if not, that's okay too. But if there's anything that you're finding works well for you, just throw that in the chat as well.
Thanks, Julia. Next slide, please. So there's benefits. I'm going to go through the benefits and the risks of doing team-based care. So these are the benefits. They're listed here. There's 2 slides for benefits. For the patients, improved and timely access is something that is a hot topic nowadays. Holistic and person-centered care, safer care, We're improving continuity and coordination of care, and it's cost effective in the long run, even though it's not may not be cost effective initially, because you're paying that many more people. It does save costs in the down the road, in chronic disease management, keeping people out of emerge and whatnot. Next slide, please. Um, Team-based care also helps you to address population health um, and equity, filling the gaps in healthcare. There's better outcomes in preventative care and cancer screening. And like Julie was saying, enhanced patient experience. Patients like a team approach, and they have greater confidence in their care. Support again for the aging population. Our aging population is growing rapidly. We need to care for these people. Yeah, and improve management, self-management of chronic healthcare issues, as people are. I think people are getting more education and more, how do I do this at home? Anything to add, Julia?
Nope, I think that covered it.
And Julie was also mentioning before the provider benefits, increased job satisfaction and reduced burnout. You have more people looking at your people, more people looking at your people, more people looking after your patients, and more hands in that can help people through their journey. Um, there's a focus on expertise among team members that can lead to more efficient teamwork and improve efficiency. Next slide, please.
And I think part of that in improving job satisfaction as well, if you do work with a team, really important to create opportunities for that team to also have fun together, not just work together. So again, working in multiple different team settings, the ones where we have more team social activities or we're encouraged to have fun together, it makes for a much better outcomes, even for patients, because everyone wants to work together. Everyone likes each other. So if you do have that team-based care, super important there to have fun together to make a more cohesive team for sure.
Absolutely. Totally agree with that. Thanks, Julia. So healthcare benefits, obviously team-based care has been shown to reduce costs, improve system capacity. Maybe we can see more people or have more people on our rosters, maybe. And stronger community ties. So we see different different providers have different connections, and different community supports can tie into the care for people. Next slide. There's always a downside to anything. So team-based care is no exception. Team-based care can be costly upfront. You're paying for more providers. There needs to be processes in place to avoid missing anything, like your diabetes visits, who's responsible for what. And adequate funding is needed to do team-based care properly. We have the conflicts arising that we talked about before, but having an open communication with your other providers, and knowing what your other provider scope of practice is really important. Who would do what? Education is sometimes needed, well, always needed, I think. Nursing, I can only speak for nurses, as they have quite extensive education to work collaboratively. And it requires regular evaluation to make sure everything's going okay, and then and what is missing, or where can we improve things.
Hmm.
Next slide.
I
Oh,
think
sorry.
we can kind of answer Rama's question. Hopefully, I pronounced your name correctly. You know, being if you are a solo physician or a solo, and there's not a lot of opportunities for nurse practitioners to be solo practitioners in terms of an OHIP based care, but unfortunately, with the lack of funding right now, that it is not typically an option for the patients from a solo physician to get care from a family health team or an NPLC or a CHC. And that's part of the funding issue, unfortunately. And so I know Teresa previously mentioned, and you'll have to talk about it a bit more, the alliance option. I don't know much about that, but I think Teresa's a bit
Yeah,
more
so
familiar.
yeah, if you just Google Team Care Alliance, it'll pop up. So it's a program that is put on by Alliance for Healthier Communities, who have put on this Team Care. You can connect with other teams. And I'm not sure how it works, but there is a little overview of how it works, and there's a contact at the end, Jennifer Rayner, and has their email and everything, and she's very nice to connect with. So, yeah. So if you're a solo physician, please reach out or at least look it up and see if it's appropriate for you.
Yeah, and that would
Um,
apply, I assume, too, for a clinic as well. So for a FO, or any situation where they don't have access to funding for team-based care. So, yeah, so hopefully that answers that question for you.
Absolutely. So full scope. So in order for a team based care to work well, all professions must work at their maximum scope of practice. So each profession knows what their maximum scope is. We do a lot of education and we know a lot about each of us as a profession knows what our scope is. So having team meetings, like maybe the initial team meeting to discuss that. And then what I talked about before is the processes must be in place for flow and care pathways. Um, Standard order sets could be a thing as well. So make sure nothing is missed and no one is left back. So these are just a list of the team-based care initiatives that I'm involved in. And I know Julia has a great list too. I just wanted to point out the RNs and RPNs. You know, our RPNs are doing intakes and doing healthy person physical exams. They're also doing well woman checks and well child visits, but they have the knowledge, skill, and judgment in order to do that. And they know that we're here, and if they have any abnormals, they come to us.
And just to also point out, that also includes cervical cancer screening. So they are able to do that if they have the skills to do it, if they're trained. So a great
Absolutely.
resource.
Yeah. And then Julia is going to talk about what other examples of team-based care and what are some of how do you use team-based care, your team members. Next slide, please. And this is just the resource list. It'll be available to you in the tip sheet. On the second last one is Team Care Alliance for Healthier Communities is the connection for that, what I was talking about for solo physicians. And over to you, Julia.
Thanks, Teresa. Okay, so I'm gonna get a little bit more specific in terms of what types of clinics or specialized care can these different providers provide within the clinic system. So there's many different interdisciplinary healthcare clinicians. They have an incredibly vast knowledge in their area of expertise. Oftentimes, they actually also are able to provide longer appointment times, which allows more time for that assessment and health education. And as Teresa said, that allows patients to better manage their own chronic diseases, which results in less visits to the office, which is great. They can provide care in many different domains, but they need to be empowered to utilize their full scope of practice. So these are just some examples. This is by no means an exhaustive list, especially with dietitians. I don't think I ended up finishing that list, but so chronic disease management, weight management, they can also be involved in breastfeeding, feeding picky eaters, nutrient deficiencies, allergies, intolerances, those sorts of things. Pharmacists are an excellent resource. So not only for, clinicians to message to say like, I have this medication question. That's what I use them for often. But they can see patients in appointments for chronic disease management, medication reconciliation. You know, those patients you have with the huge long lists of medications. You don't know what they're taking, what they're not taking. Pharmacists can fix that for you. Chronic pain, INR clinics, smoking cessation and addictions, and that includes nurses, nurse practitioners, all sorts of providers can be involved in that care as well. Mental health counselors can do all sorts of, obviously, counseling, individual, family, marriage, pregnancy, and postpartum health. Nurses are a wealth of information and opportunities. Again, more chronic disease management, INR, foot care, cervical cancer screening, as I mentioned before, and again, smoking cessation and addictions. And so on the next slide is just a couple more different types of clinicians that can be used. So physiotherapists, occupational therapists, chiropodists, respiratory therapists, these are just some examples. I won't read through them. You can obviously see them there. Again, this is not an exhaustive list. So knowing the scope of practice of the clinicians that you're working with is really, really important. But these are just some examples of some of the things that they can do and some of the opportunities that they can provide for patient care. So the next slide. So, you know, my obvious area of expertise, and Teresa's as well, is nurse practitioner, sort of specialty clinics that would be available within a team setting. Just a reminder that nurse practitioners are autonomous healthcare clinicians. They do not require supervision by a physician to provide care. So something that's really, really important to know there. They're a great resource to run all sorts of clinics that require more complex elements of assessment, diagnosis, management, and different types of procedures. So they come from a ton of different nursing backgrounds. That's sort of one of the benefits is before becoming a nurse practitioner, all NPs are RNs before that. And so the vast areas that NPs come from is incredible. So lots of great knowledge there. So some of the things just to show that what they can do: assess, diagnose, order and interpret diagnostic tests, prescribe medication, perform minor procedures, and can manage acute and chronic illnesses. So really, for the most part, whatever a primary care physician can do, a primary care nurse practitioner can do as well. And in both cases, as long as you have the knowledge, skill, and judgment to do it, you can do it pretty much. And then just reiterating that we don't require a physician supervisor to provide care. So some of the clinic, just go back one more quickly, just some specific examples of the types of clinics. The one that I am involved in here at the Center for Family Medicine is the Women's Health and Procedure Clinic. So we do all of that, or not all, some of the physicians do some of these things. IUD insertions and removals, endometrial biopsies, pregnancy counseling, including medical abortions, vulvar biopsies, pessaries, Nexplanon insertions, menopause and perimenopause care, contraceptive counseling, sort of anything that you can think of in that area, we do. And there's a specific clinic day 2 times a month that patients can be booked into this clinic, where we have a nurse that supports us and a specific booker that helps us to book into that clinic. Breastfeeding clinics are another one. I know from a personal experience with my daughter, I went to a breastfeeding clinic and it was run by an NP. She fixed the tongue tie. She did all the things. So, so she was being used in that way. Minor procedures. Anything that is a minor procedure that can be done in primary care can be done by an NP, obviously as long as they have the training. Travel clinic, smoking cessation and addiction. So wide variety of options there. And that's, again, not an exhaustive list, obviously. Any other specific things you wanted to add to that, Teresa?
Yeah, I just wanted to bring up that we have a geriatric clinic that we run here to keep our ALC population in the hospital down. So we're connected with a hospital. And we also have a memory clinic as well.
Yes, both things that I've worked with at family health teams as well. It's great, for sure. Awesome. So internal clinic referrals. So the point of contact for a patient when they're first contacting any clinic is going to be, it can be a receptionist, it can be the nurse, it can be a nurse practitioner, it can be a doctor. So it's really helpful to have a consistent system of referral within the organization so that patients have really dependable access to these specialized clinics. And it makes it easier for everyone. If the referring clinician or referring person, even if it's a receptionist or administrator, as long as if there is a clear path on how to access these clinicians, you're more likely to do the referral. Or put people into these clinics or into these schedules. So use your EMR custom forms to create a single form to access all specialty clinics and providers. That's one way of doing it, right? Another way to do it is, you have a access to a list of who's working in each specific clinic, and maybe you send a individual message or referral letter to that specific person. As long as it's streamlined and consistent, that's really what matters here. Um, any necessary referral criteria or additional required forms should be included by the receiving clinician. It should be clear on what you require in order to see that patient. So for an example, for an IUD insertion, one of the things that we offer is Penthrox for pain management. So a pop-up comes up if that's something that the referring clinician is offering. And then it gives them all the information on what to tell the patient about that they need a driver to get home, that they can't have any sedatives or alcohol on the day of their appointment, those sorts of things. So it needs to be very clear so that the person sending the referral can give all the information necessary. An area of free text is also important to give all the extra information. In our case, an automatic message goes to a booker. That can be receptionist, the nurse, the receiving clinician who's going to be seeing the patient, to help call that patient and get them booked into the schedule. Again, that's one way of doing it. If you work in a small team and it's fine, for the, referring person to just put that appointment into someone else's schedule, if you have that trust and that relationship, great. That's a great way to do it too. But again, really consistent is what's important. Updated wait times being sent out to the referring clinicians in the team regularly so that patients have at least a bit of an expectation of how long it's going to be to wait for that next appointment. And then once somebody sees a patient, important for a note to be sent back to whoever did the referral so that they know that they've been seen and they can see what the plan is. Next slide. So this is just an example of what we use here at Center for Family Medicine in terms of an internal referral form. You can see all the different, we have some physician specialty clinics, the dietitians, the pharmacists, the nurse practitioner, and then there's some hyperlinks there for specific lists or requisitions or different ways to do the referrals if it's not, if that particular person doesn't want to receive the referral through the referral form. But it's still listed here so that it's one-stop shopping. And then the next slide is just a continuation of that form, including nursing, social working, occupational therapy, travel clinic, and our COPD clinic. So that's just an example of how you can use your EMR to help with this team-based care. And then this is just for your further reading. This will be sent out to you. It's just the different scopes of practice of some different types of clinicians. Again, not an exhaustive list. You can easily Google scope of practice for any type of clinician and just go specifically to their regulatory body website. You'll be able to find all that information. And that is it from us for now.
Wonderful. I do see, we do have a question in the chat from Trevor. I don't know, Julia or Teresa, if you can see the question there and would like to speak to that.
So that part one might be better for Teresa since you're sort of more in more leadership role at your.
What's MOA level?
Now I can't even, it's escaping me. Trevor?
Oh, yeah, okay. Yeah, so so the team-based care we use, we're a smaller team, so we message each other. Our physiotherapist does require more of a in-depth, and she does triage her own cases. Yeah, and then we felt a big ad for team-based care is a nurse coordinator. Yeah, for sure. Coordination of care, very important. Julia, anything else to add?
Yeah, well, I was gonna say, like, we do have our dedicated bookers tend to be the receptionists for most of the clinics. We have dedicated, we are a big team, so we have a lot of people on our reception team over multiple sites. So they will take on that extra work. So specifically for the Women's Health Procedure Clinic, we have Samantha. Every time someone does a referral, a message goes specifically to her. She knows exactly how we like to run our schedules, exactly, an email that might need to go to a patient in terms of information. She's got handouts that she sends people. And then there's a different booker for each type of appointment. So for my smoking cessation appointment, it's Kira. So there's very specific people, and that keeps it really streamlined.
Excellent. And I see, Teresa, there was another one in there addressed to you.
Yeah, sorry.
How did your clinic, yeah, it's okay. How did your clinic decide to have physiotherapists see patients initially for MSK injuries, and what type of injuries are included?
Yes, we haven't really started that yet, but it's an idea that our physiotherapist is so busy with the things that they are doing now, seeing patients after an injury or after a knee replacement or a hip replacement. So we haven't initiated that, but I mean, things that they could see is knee injuries or shoulder pain. And I think they can see things initially and then collaborate with us for a plan of care.
Excellent. Any other questions?
And
Marilyn
Julia and
had a
Teresa.
question
one
for
from Maryland.
digital, yeah, digital opportunities for collaboration across practices. So the Alliance, again, the Alliance for Healthier Communities has that team care program. I'm not even sure if you have to pay for that as a provider or what is specifically involved. I think they connect you with a team in Ontario, and there's Jennifer Raynar is the connection person to connect with.
Yeah, and in terms of digital opportunities, I know that's sort of part of the reason for these this webinar series is to figure out these ideal primary care practices and sort of reaching out to amplify and kind of, and correct me if I'm wrong, Andrea.
Yeah, no,
And, letting them know like this is what would make my
absolutely.
practice the ideal primary care practice. These digital tools that do this, 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 and I know Amplify Care really encourages pie in the sky ideas, like anything. If you had unlimited cash, what would you want? And their goal is to help meet those needs and to help figure that out.
Yes. Okay, wonderful, wonderful. I do see in the chat the email for Ms. Rayner. So following this, we do provide a tip sheet. We will put Teresa and Julia's contact information on there as well. But I do want to say heartfelt thank you to Julia and Teresa for an outstanding presentation. Your insights are truly invaluable, and no decision about us without us. That's a great one. We'll take that away. We also want to express our gratitude to everyone who joined us and took time to participate today. Your involvement is greatly appreciated, and we look forward to seeing you at our next webinar. In the meantime, we invite you, as Julie said, reflect on the questions above and share your thoughts with us via email. Your feedback is instrumental in shaping the future of primary care. Thanks a lot, everyone. Have a great day.